Thank you. Good morning still, and thank you all for still being here, for sticking it out. So I'm going to talk about the treatment of achalasia in some special situations. I have no disclosures. This is the outline for my talk this morning. So it's kind of a smorgasbord of comorbidities or special situations in which you may have to consider treating achalasia. So first, morbid obesity. This could be its own talk, and it actually was last year. So I'd like to acknowledge my partner, Anna Eibel, for her help with that portion of the talk. Hiatal hernia, revision, and megaesophagus. So first, morbid obesity. This is a little bit counterintuitive. The first time I encountered a patient with these comorbid conditions, I was a little bit surprised, but it is happening with increasing frequency, and this is a real entity that most of us will encounter who are treating achalasia with any frequency. So I think one thing that's important to stress here is patient autonomy. We'd like to encourage the patient to have the treatment that would treat both of these comorbidities simultaneously, and I will address that. But if the patient really just wants to have their symptoms of achalasia palliated, then we should offer those treatment options to patients who are morbidly obese as well. However, if your patient is interested in bariatric surgery, gastric bypass would be the bariatric procedure of choice to combine with treatment for achalasia, possibly a Heller. And POEM is also an option in terms of combining with gastric bypass. So what to offer? These are basically our standard options for durable treatment of achalasia. We have pneumatic, we have Heller, and we have POEM. So any of these treatments could be offered in this setting. And our optimal treatment choice would probably be the combination of a Heller and a Roux-en-Y gastric bypass. This is a picture of a pneumatic. One thing is that if your patient has already had a gastric bypass, a pneumatic is probably not a good option, because in order to get the pneumatic balloon seated with the middle of the balloon at the EGJ, as you'd like to for treatment of achalasia, that balloon will probably overlap the gastrojejunostomy. So if your patient has already had a gastric bypass, that may no longer be an option. So combining laphellar and Roux-en-Y gastric bypass has been done, and there's at least one series published on this. This would provide, excellent treatment of dysphagia related to the achalasia, as well as prevention, really, of reflux after treatment of the EGJ outflow obstruction, and durable weight loss with all of the benefits associated with that. So from a medical standpoint, I think this would really be the gold standard in this setting. Some technical pearls. You may choose to perform only an anterior phrenoesophageal membrane dissection in this setting. You should be facile with intraoperative endoscopy if you're going to undertake this combined procedure, I think, because it could be useful for multiple reasons. One thing is that you're not going to have a lot of wiggle room, because in order to effectively treat achalasia, you want to have a 3-centimeter gastric myotomy. But our optimal pouch size for gastric bypass is about 4 centimeters. So that doesn't leave a lot of distance. So I think if I were doing this, I do a circular stapled EEA for gastric bypass. So I would do that portion of the procedure first, and then do the myotomy after I had formed a GJ. But if you're doing a linear stapled technique, you may not have to order things that way. So what about combining a laphellar and a sleeve? This is not something that I would recommend. As we heard this morning in an excellent session, reflux after sleeve is really an active area of investigation, but there's probably de novo reflux in about 30% of patients after sleeve. And we know that patients who have treatment for outflow obstruction from achalasia are also at risk for reflux. So that's not something that I would recommend. We also know that patients with achalasia long-term have a higher risk of esophageal cancer. So if they, in the rare occasion that they would go on to require an esophagectomy, they've just lost the first choice conduit if they've already had a sleeve gastrectomy. So I think we should try to avoid burning bridges. What about achalasia after bariatric surgery? Well, I already mentioned a point of caution about pneumatic dilation, but really first and foremost, rule out pseudoachalasia, especially in the setting of a lap band. That's probably where you're most commonly going to see this. Oop. Okay, so next, hiatal hernia. What if you have a patient presenting with achalasia and hiatal hernia? Well, basically in this setting, I would recommend surgery because you can address the hiatal hernia at the same time. You can perform a hiatal hernia repair with a hellar myotomy. Any endoscopic management of achalasia is not going to provide management of the hiatal hernia simultaneously. So I think that's important, and that would be a pretty straightforward recommendation. One point of caution here, this manometry image is the composite picture from a patient who I operated on actually at the beginning of this week. And he was referred to me for a type 3 paraesophageal hernia and type 3 achalasia. And if you get a patient like that, you want to be really cautious and review that manometry yourself or with another a GI doctor, whoever you trust who's reading manometry at your center. This patient did have EGJ outflow obstruction, which was related to the paraesophageal hernia. You can see that the peristaltic pattern also looks abnormal, which is what tripped up the person who originally read this study, but it wasn't actually a spastic pattern as you would see in type 3 achalasia. Rather, it was more of compartmentalized pressurization in the distal esophagus that was related to the paraesophageal hernia. So if you do get a referral like this, try to apply Occam's razor. And keep in mind that more than likely the motility abnormalities that you're seeing on the manometry are actually related to the hernia. So another special setting is revision. I kind of think about this like, or I think you might think about this kind of like a recurrent inguinal hernia. So think about how the operation or the procedure was done in the first place and if it might reduce morbidity for the patient to address it in a different way if they have recurrent dysphagia. So if they had a Heller before, you might think about referring them for a pneumatic or doing a poem, or the reverse, although you can repeat any of these procedures as well. In terms of a redo Heller, think about how exactly the operation was done in the first place. The type of fundoplication that they had initially can affect the difficulty of doing a redo. For example, if they had a toupee, you would expect that their myotomy site might be adhesed to the diaphragm anteriorly, which can be a difficult dissection. If they had a door, that may be relatively more protected. The myotomy may be relatively more protected, but in either case, you're going to have to take down the fundoplication enough to have access to an area of esophagus where you can perform a new myotomy. So what about megaesophagus? I think that we have literature that bears this out, that patients deserve a chance at treatment of their outflow obstruction before they have a resection. So I think that you should offer a patient with megaesophagus a Heller or a poem or a pneumatic to address their outflow obstruction before you would recommend resectional therapy like an esophagectomy and try to avoid the morbidity of that procedure. We have literature that shows that most patients with type 1 achalasia, at least, can be effectively treated with sort of our more standard treatments for achalasia. And I think a lot of patients with megaesophagus can be too. I would say that if you have a patient whose megaesophagus has progressed to sort of this sink trap configuration, that in that case I would recommend surgery because your mediastinal dissection can then sort of straighten out that lower esophagus and provide better esophageal outflow. However, if they don't have that configuration and they just have megaesophagus, there are definitely experienced poem providers like Dr. Dunstall you'll hear from later who would say that poem can be done in that setting, probably only by very experienced providers. So in summary, it's important to consider the whole foregut picture and consider unique patient factors that may affect your treatment choice for achalasia so that you can get the best overall result for the patient. Thank you.